And we should be on full screen now, docs, everybody? Yeah, perfect. All right, so doctors, let me introduce myself. I'm Jeffrey Taylor, and I've been teaching for progressive ortho since 1987. So you can do the math on that. I'm the most senior instructor we have after Dr. McGann retired a few years ago. And they asked me to put together a little presentation for my potential students as well as my current students and graduates and so forth regarding how orthodontics can influence your practice and make you an overall better practitioner and provide a better service for your patients as well. So this is like a miniaturized version of our intro class that usually is an 8-hour class. So let's talk about some terminology for those of you who are not familiar with orthodontics. And yeah, so that looks good. So in the USA standard, we're the only country in the world that speaks like this. We number the teeth at 1 through 32, and everyone else in the world uses this international system, and they call them the teeth are 1 through 8 in the quadrants 1 through 4. And American orthodontists use a thing called Palmer notation, and it's very similar to the international notation as well, where they have teeth 1 through 8, where 1 is a central incisor and 8 is a wisdom teeth. And there's 4 quadrants in the arch. So in other words, the upper right quadrant is quad 1, lower left is quad 3, and so on. Doctors, we should be looking at ortho and you again, correct?
Yes, sir.
All right, perfect. And now are we looking at numbering systems now?
Yes, sir.
Yep.
So we're good. All right, so back to work. Sorry about that digression. So we number teeth 1 through 32, and this is a really hard thing to get out of your head because you've done it for so long, but we speak in the international system or the Palmer notation system, where we divide the quadrants into 1, 2, 3, 4, and the teeth central incisor is a 1, an upper cuspid is a 3, and a wisdom tooth is an 8. So you have all seen this numbering system when you refer patients to an an oral surgeon for extractions. Then you circle these numbers so there's no doubt in anybody's mind about what is supposed to be done for the patient. And similarly, orthodontists speak this way all the time. So that's how we are going to do it in the POS system because, of course, we're an international company. And next, we'll look at an example of that. And all of you know 14 in Palmer notation, that's upper left because that's the quadrant. It's the 6th tooth from the front, so it's an upper left 6. And the international system, it's called a 2-6. And it's stated 2-6, not 26. That's the normal way to do it. And another example would be your lower right cuspid is a 27 to you, but that's a lower right 3 or a 4-3 in international speak, okay? And now, I don't care what aspect of dentistry that we're doing, whether it's orthodontics or endo or perio or whatever it is, these 3 criteria must be met for the case to be successful. And obviously, does it function well? Can the patient eat and speak and do everything they need to do with their oral cavity? And is it aesthetically pleasing? In other words, is everybody happy with the way it looks and the aesthetics of it, especially the patient? And the third thing, like the most important thing perhaps, is will it last? And by that, I'm sure all of you, if you're old enough, you remember composite bonding when that hit the market big time, and we were smearing composite on anterior teeth all the time to make them look better. And of course, that looked really nice at the beginning, but it didn't last worth a hoot, and that's where veneers and so forth were born from that. So we use the same criteria for ortho. We would like our cases to be nice looking and work well for a long, long period of time because this has to last the patient forever, so to speak. All right, so I see 3 things in the chat box. Let's see what's in here. Oh, just people saying hi to the staff. So hi back to all of you. And now the basic orthodontic goals for any case that you're going to embark on, that's a full case that is a proper anterior-posterior relationship. And you folks should know that as class 1, 2, or 3. So it's working in the anterior-posterior plane of space. The transverse relationship is referring to the crossbite in the posterior teeth. So, excuse me, does a patient have some kind of a discrepancy? Usually the upper narrower than the lower, but the upper can be massively wider than the lower too. And we call that a telescopic or a scissor bite. And then a vertical relationship, they can be open, they can be deep, they can have vertical, they have open bites because of habits and so forth. So we have to look at all those things as well. Plus aesthetics and phonetics. And does this patient speak well And does it really look good to the patient? And of course, today we have to pay extra attention to the facial aesthetics. Orthodontics in the 50s didn't pay that much attention to facial aesthetics. They were more concerned about just what did the teeth look like and what did casts look like. But today, patients are so much more particular about what they get from the aesthetics of their face. So we must consider that for every patient that we treat. Okay. And I modified Andrews' 6 keys to occlusion. And Larry Andrews was a very, very prominent orthodontist in Newport Beach, California. And little did I know it, but when I was going to school, when I was in high school, I would go right by his office every day because it was only about 2 blocks from where I went to high school at Newport Harbor High. And now there's a whole bunch of Andrews offspring, and they teach there actually down in South County, San Diego neighborhood. And he came up with these 6 keys to occlusion, and I kind of modified them because the terminology he used was a little more difficult. But obviously, you want to get a class 1 cuspid and molar. And we get this question all the time about why is class 1 cuspid so important? And when we see some case examples today, I can explain it better, but let me give you the short version right now. And if you have a class 1 cuspid and it's interdigitated properly with the lower arch, that means your anterior teeth fit together. So the 4 upper and the 4 lower incisors articulate correctly, and they're called mutually protective. And they also will guide you in excursive movements such as lateral and anterior excursions, and so on and so forth during mastication. So that's why a class 1 cuspid is important. It's not something that was just made up. It really has some meaning to it. And oh yeah, so people logging in are making the dinging sound. I don't think I can turn that off. And proper overjet and proper overbite. And you and I call, excuse me, you and I call overjet is the anterior posterior dimension. Overbite is the vertical dimension. And it's interesting that patients usually say it backwards of that. They say overbite is like a big giant class 2 with a big overjet, but in reality, it's overjet. So if you have a big class 2, you'll see that here in a minute, then you're going to have a big overjet in general. And all the teeth should be rotations corrected, and there should be no spaces present in either arch. And we always treat to a flat curve of Spee. And this is one of the mysteries of orthodontics, at least to me, because everyone has a curve of Wilson and a curve of Spee, but when we treat to ortho, we treat to a flat curve of Spee. And seeing patients for 40 plus years, I can tell you that the curve of Spee usually relapses in almost all patients. So the fact that ortho treats it to a flat curve of Spee is still somewhat of an oddball thing to me, but that's how we do it in ortho. Okay, so let me go down here a little bit since I'm not advancing normally. And the orthodontic class 1 classification is a little bit different than what you learned in dental school. And this is just like the numbering system. It takes us a long time to get this out of your head about what the class 1 position, especially the molar, is. But the cuspid is pretty easy. It's the upper 3 cusp tip over the contact of a lower 3 and a lower 4. And here's the one that's different that amazes everyone is the molar class 1 is the distal buccal cusp of the upper 6 is on the mesial marginal ridge of the lower 7. And I'll show you why that happens here in just a minute. So here's what you learned in dental school, and this is what you can't get out of your head. It's the mesial buccal cusp of the upper 6 over the central groove of the lower 6. And why is that different than ortho class 1? And the short answer is the curve of Spee. So let me show you an example of that. So over here at the start, you can see this is a little teeny bit of class 2, the way you know it from dental school. And you look over here and you have the distal buccal cusp of the upper 6 on the mesial marginal ridge of the lower 7 with a cuspid in the class 1 position right between lower 3, lower 4. Right, so that looks nice. And again, the same thing, a nice class 1 cuspid and then orthodontic class 1 molar, where this looks like your dental school class 1 molar, but now it's different. And it's different again because of the curve of Spee situation. So let's go look at that here. And if you have a flat curve of Spee, then you end up with class 1 cuspid and a molar classification that looks like a slight class 3. That's what you would think. But in reality, that is the true molar position. And the red lines indicate the dental school class 1. So in a minute, we're going to look at some cases. And then you might question, gee, why do the molars look like that? Well, now you know why we have that discrepancy. And again, this is not something I made up. This came from, again, Larry Andrews. The Six Keys to Occlusion, 1972, and he talks about the position of the molar relative to the lower arch and so forth. So this is something that's been in the literature for ages. And doctors today, you know, everything is going digital. You've been digital x-ray for a long time, and now we're doing digital models. And this is one of many, many companies that do digital models for you.
Hey, Dr. Taylor, I'm going to reclaim the host really quick to change the settings so the alarm or the beep notification goes off, and we'll go from there. Sorry about that.
I can still talk though, right?
Yes, of course.
Oh yeah. Okay, so here, what is one of the the many companies that do digital models, and there's a number of ways you can do this. You can take an impression and send it to them wet. You could send a model to them, and you could also today you can have a scanner in your office and you could scan this. And there's a thing called Ortho, 3D scan that you can make an ortho model out of it. And the patients are definitely wowed by this. And if I had more time, I would show you this website, because you can manipulate this model exactly like you have it in your hand. You can rotate it around. You can look at it from all angles. You can open it up and look at the occlusal view. And it takes a little while to get used to that if you're used to handling a cast. But today, this is the way everything is going. And it's such a huge advantage, because then you don't have any model storage and all that kind of stuff in your office. So by far and away, I don't think anybody should make plaster models today. I think this should be your record for the orthodontic record. You could make a cast to do a diagnosis and stuff, but later you'll throw that away. So hard models are pretty much a thing of the past as far as I'm concerned. So let's scroll down here a little bit more and consider the following cases as examples of what a great, valuable, and rewarding service you could start providing for your patients right now. And don't forget, it can be quite profitable as well. One of our other senior instructors, Joe Viviano, has a full breakdown of how economically advantage, what a huge economic advantage it is to start doing orthodontics in your practice. And once you have a good system, it can be every bit as profitable as crown and bridge and implant therapy and so on and so forth. So I know in the beginning it won't, but once you learn about this, it is quite nice. And
I can't do anything without every time I move, it feels like.
Hey, wait, Roger, you're talking in the background. Can you mute your mic for me, Roger? Dr. Garrett? Oh, thank you. Okay, so it can be quite profitable, but again, the learning curve is pretty steep. And the other beautiful thing is most of orthodontics, the way we do it today, is actually done by a dental assistant. You use your brain and they use their hands. So even if you're hurt somehow, like, you know, you broke your wrist or whatever, and you couldn't do dentistry, you could still do ortho, because the dental assistant is actually going to be providing the hands-on part. You were just directing her. So let's look at a bunch of little cases just to see what could be done in your practice. And so here's a young man who's years old at the start, and you can see he has a lip incompetency right here with a deep sublabial fold. He's got strain to close. He's got a huge overjet. You're going to see that here in just a minute. And here we go about 12 months later, and you get a very nice finish. And look at what much better facial balance he has. This is a really, really nice finish. And you would look at this and think, gee, this is really a difficult case, because you've got like a 14 millimeter overjet, and you're going to finish that down to a proper overjet of 1 millimeter. So I put that in there kind of as a joke. This presentation contains images you might find offensive, because the malocclusions might be pretty strong, and you think, gee, that's really a misfit patient. But these are all just normal everyday orthodontic things that we see. So that's a very nice case. And here's another view of it. And the big giant overjet, you can't see it in this plane of space, but here you can see very, very nice finish. The teeth interdigitate beautifully. Everything is great. And we always say a case that finishes well will usually retain well. So we expect this guy to be stable for a long period of time. And let's see how we did with the roots. And did the roots get in pretty good alignment? Yeah, everything looks pretty nice down the whole side. This lower sevens aren't in yet. The 8s need to go away so we can get those 7s in. So he's probably like 14 or 15 by formation of the cuspids down there. I'm sorry, the wisdom teeth. And again, here's a young lady who was 13 at the start, and she was unfortunately biting on her incisors for the start photographs instead of in maximal intercuspation like she should have been. So I apologize for that, but you'll see in a moment, she's a full class 2 division 2. You might not know what that means yet, but at the end, she again looks really great. This was about a 2.5-year case because it was kind of difficult. And this is the real occlusion at the start with 100% dental deep bite. That's kind of a tough thing to fix, and the cuspids haven't come down yet. And here, look at the nice finish you get at the end. Everything looks great. And here, again, you remember from our discussion about 10 minutes ago, this is a very big class 2. This is about 5 millimeters off, and this is about 5 to 6 millimeters of class 2. This is class 1 with the upper 3 right between lower 4, lower 3. So this is very, very nice. And look at this one. And this is, again, a giant class 2. There's about 7 millimeters per side, and you finished with 0. That is a great finish. And we look here, and we have 4 bicuspids still present, 2 cuspids, 4 incisors. Everything looks great. And we look on the bottom. Nice straight teeth. Everything is good. Still have all the bicuspids present and so on. So how in the world did we fix such a giant class 2 if we didn't take out any teeth? Well, you just don't see what teeth were taken out. And the answer is the upper second molars were taken out. So doctors, these upper 7s were taken, and then the 6 was pushed back, plus using growth and this distalization concept, we ended up with a beautiful finish. And these 8s are going to come down and substitute for the 7. And no one will be the wiser that those are not the second molars that should have been there in the first place. And doctors, this is a beautiful thing. If you have an adolescent or say a young adult that comes in with an upper second molar that's completely destroyed by caries, you think to yourself, well, gee, I need to do an endo and a post and a crown lengthening and all of that other stuff. That might total, say, $2,500 to $3,000 today. Or you could put an implant in there for $4,500, or you could do an ortho case for $4,500 and get all brand new wisdom teeth in there instead of that second molar. So again, the restorative possibilities are huge once you start learning and start doing ortho of what can be done for your patients. And here, this is a very old case, but a very nice one, a nice young lady at age 12. And she finishes with good facial balance. Everything looks really nice. And she was pretty jumbled up. And all of you have seen this in your young patients. And, you know, patients hate this with the high cuspid thing, sitting up here and up here. And when they laugh, they cover their mouth because they're so embarrassed about those vampire teeth. That's what they usually call them. And anything you could do to make that be better, she would be much better off. So of course, we just took out 4 bicuspids, and then you brought these cuspids down in a very, very short period of time, maybe like 3 to 4 months. And you get to be an instant hero in her eyes. And look at, again, what a beautiful finish you have. And a typical 4 bicuspid extraction look to her case. But the profile looks great. The incisor actually stayed at start position. We just used the space to bring the cuspids into the arch. And this young lady has pretty big teeth. And look at how beautifully everything fits together at the end. And doctors, you all could do this once you're trained to do it. And I don't know if it was like that in your dental school, but everywhere I go in the world, I find out that dental schools usually say that you cannot do ortho. You are just not smart enough for that. You should refer it to an orthodontist. And that is so not true. Every other specialty of dentistry, you know, they teach us how to do endo and perio surgery and wisdom teeth removal and everything else, but they don't teach us how to do any ortho, which is a shame because that's such a valuable service that we can provide for our patients. And I think currently today, 66 or 67% of the ortho cases done in America are done by GPs like us. So again, back to our little girl, she got 4 bicuspids extracted so that we could bring the cuspids in on the upper and the lower arch and maintain a class 1 occlusion. So that looks great. How'd we do on the roots? Looks pretty good. So here we are at the end. And all the roots look pretty nice and parallel. Everything is good. Let's see if this is a question coming up here. And Dr. Cabby says, could palatal expansion work instead of bicuspid extraction? And that's a very, very logical question. And when we look here, back at this slide, back here at this slide, the crowding is in an AP direction, right, doctor? In other words, I need to move the front teeth forward or the back teeth back to make that cuspid to come in. And if you move in a transverse direction, it really doesn't help you that much to make an AP correction. So in general, crossbite or expansion is done for crossbite correction. It is not done for crowding. And I know many modalities teach something and they call it arch development because that's a fancy word for expansion. And they develop the arches before anything else happens. And a lot of that usually relapses. That's why we don't do it in the POS system. So good question, but the short answer is no. And we only expand for crossbite correction. We do mild wire expansion in the lower to correct crowding, but that happens in our phase 2 treatment, not our phase 1 treatment. So good question. All right, so where were we? Oh, we were back here looking at our roots. And let's see how that looks. All right, so very nice roots and so on. And let me just show thing will work again. And no, still stuck on that. So my apologies. I do a ton of Zoom stuff. I've never seen that before, so I don't know what the problem. Interesting case too. And study this image right here of her front view. And can everybody see how her mandible is shifted off to one side? And I hope the answer is yes. And she has such a messed up occlusion that she has a functional shift of her mandible to get her into a proper position. And this can result if it's left untreated. Many patients tolerate it just fine, but a lot of patients don't tolerate it. We'll find out what it looks like at the start. I mean, here in just a moment. And this girl's 24 at the start, and here she is at the end. Notice that the shift in the mandible is gone, and she's got quite a gingival display, but that was never one of the goals. That didn't bother her at all. So that was not treated because that would probably be some type of a surgical correction, and she was not bothered by it. So let's see what a mutilated dentition she has at age 24. Lower's not too bad, but look at all this mess in the upper. She's already missing a couple of molars and a severely blocked out lateral and a crossbite, and the root of that thing is up on the palate. So we have now taken out 2 lower bicuspids and then put the molars. The 7s took the place of the 6. So we did another molar substitution like that. And look how nice that looks. Look how nice that looks compared to what she started with. And again, this is no restorative. This is all just ortho. And here, looking at the the lateral view, the cuspid has like a pretty close to class 1 in it. This is pretty close to class 1, and this open bite type of tendency, missing those teeth. And look at how nice this came out at the end. And certainly not perfect, but a lot better than any other restorative thing that you might have thought of doing had you not known ortho. Right? You see these holes and you want to stick something in those holes like implants or bridges so that you can have instant income. But the best thing to do, of course, would be to fix it without any prosthetic stuff, all natural teeth. So let's see how we did on her pano at the end. And she's pretty jumbled up with some bombed out teeth. They were hopeless. So we ended up just extracting them, and then the wisdom teeth came in, and look how beautiful that is. We ended up restoring this one because that's a harder thing to fix, is getting the lower wisdom teeth in. But here the upper 8 looks really good. Sinus height's pretty low, but in spite of that, we still had a pretty nice result. All right. Let's look at another one. And I want you to think now, doctors, for a moment. If you only knew restorative dentistry and you didn't know any orthodontics, what would you do in a case like this? And I'm pointing out to you that her midline's in the middle of her face at the beginning, pretty straight profile. And there she is, all smiley, happy face at the end. And let's take a closer look at the malocclusion and see what's happening here. Or I should say, what does she present with? Oh, isn't that interesting? So you've got a cuspid sitting next to a central, so there's no lateral there. And here's a peg lateral. You notice that the upper to lower midline is off by a little bit, yet the upper is still pretty good to her face. And look at what's happening here. All these lowers are kind of tipped over to one side like that. So remember, there's a cuspid and then a central and a lateral and a cuspid. And at the end, you have a lateral, a central, a central, a lateral, and a cuspid like normal. Midlines line up. Everything looks really good. And from an aesthetic standpoint today, imagine all of us, in California or wherever you are in America, people wouldn't like this at all, especially a 24-year-old girl with that bag or two sitting in there. They would have all kinds of comments about that one and on this one. So Again, let's look at the side view here and see we have a giant class 2. This cuspid is about 7 millimeters of class 2. This one's about 5. And here this side is a class 1. So again, a giant shift of some type. And prosthetically, we put back an implant here with the lateral crown on it. And then we built this one up to be a last see right here, and a class 1 occlusion, what you see right here. So imagine how many options this would open for treatment for your patients that are really mutilated compared to what you can do and will do now. And you know, doctors, you folks does, because really I call orthodontists pretty much like gold-plated dental students. They graduate from dental school and then they go right to ortho school, and they never had a chance to do anything except a couple of crowns and some fillings and stuff. Whereas you have done big restorative cases and so on. So you could set this up far better than they could set this up as far as restorative is concerned. At least that's been the comment from many, many people that we've had in our class who are like prosthodontists and that do a lot of prosthetic work in their office. And they said, I can't get anybody to set up the case correctly for me, so I'm going to do it myself. In fact, I work with an oral surgeon in Poland, and he says, I can't get orthodontists over there to set cases up correctly, so he sends them to me for the diagnosis, which is kind of an interesting thing. All right, so here's another young man, age 11, and he's got 2 peg laterals, one here, with a space right in the middle, kind of like an Arnold Schwarzenegger look before he got it fixed. And he's missing a cuspid over here, but it's just not erupted yet. This one's in. And let's go look down here at some more of this case. There, and mild class 2 on the left side, maybe like 3-4 millimeters, but the peg laterals are the big thing. And, you know, I'd hate to see this guy go through life with those nasty looking, you know, peg laterals being so small like that. Plus, you just can't make the teeth fit together like that when you have an unequal amount of tooth mass between the right side. So what are we going to do for him? Let's open the space up and we'll treat it with a combination of ortho and prosthetics. So we're going to crank this open with these little springs right here, and we call this open coil, which is like what's in a ballpoint pen. And you pack that coil onto the arch wire, and then it makes the space. The upper incisors will advance. And let me see if I have a share thing coming up here. And I lost my screen, but I'm still on. Yeah, okay, so we have coil spring. We're going to open up the space, and we're going to fix this prosthetically. And let me see if I can get this link to work today. No, it only works if I'm in the screen mode, so we'll just move on for that. And while we're here talking about that, and I talked about, well, this moves this way and this moves another way, how does orthodontics actually work? And what happens when you push on a tooth? Then it puts pressure on the PDL, and then the cells inside the PDL eat away the bone on the frontal side, and then the tooth will move. And on the other side, the PDL is stretched, and then that lays down new cells with new bone to follow, and it turns into osteoid, and then it turns into bone, and so forth. So when the PDL is compressed, then the bone is eaten away on the front side, and then new bone is laid down, and it's a very biologically correct situation. Everything works great, but you can't push it too hard, otherwise the PDL becomes hyalinized or doesn't have any more oxygen in it, and then the cells have to eat through the marrow space. So I can't see who's in the audience, but let me see if it works here. Probably only a handful of you guys are old enough to remember that when you had braces as a kid, it would hurt. And that's because they didn't have light forces like we have now. Nitinol, which is the wire that we use, came about in the late 1980s or the mid 80s. So that's when orthodontics really took a turn for the better. Okay, so I digress. Let me go back here. And we're going to work this all out from a scientific basis. We're going to make those lateral incisors be the exact right width. And we measure the central incisor and we base it on proportions. And doctors, those of you who have done big reconstruction cases or even just Hollywood crowns on the upper 6 front teeth, when your lab guy sets it up, this is the dimension he uses. He makes the laterals be 80% the width of the centrals, and he knows, because that's the most aesthetic look that came from the golden proportion, if you will. And that's how we make nice looking teeth. So we measure the central, we divide it by 80%, or I should say multiply it by 80%, and then you know exactly what the lateral width should be. So that works out great. And after coil packing and all that other stuff that we did up here in that previous slide, once you make extra space, then we're going to do this. We're going to put composite on those teeth. And this is an interim provisional restoration to make the parent and the mom happy. The most important thing is it makes you decide on the correct size for the teeth. Will the teeth fit together well? Will they function correctly? Is it going to be the end all size for those lateral incisors to follow? And if it's just composite, you can adjust it anytime you want to make it fit exactly as you desire. So don't make it look too good because they won't get the final restorations, of course. And now scroll down again. Let's see if we do the other side. And again, you know, don't make it look too nice. So notice this fancy matrix system. I just stick my finger in there and blob some composite on the back of that. Don't even take the lateral, the bracket off the lateral, and then roughly shape it and make it be the right width. That's the most important thing, is that you have it be the width. And docs, you should know central incisors are usually about 8 millimeters in mesiodistal width. So 8 times 8, 6.4 millimeters. That's the target width of this. So pretty much that's what we can make it be, right on the money. And then once we get it shaped up, then we zap it with the light. And notice the extra working space. You're going to close that space later. So this whole thing of making 2 lateral incisors plus tying it back together, this might be like a 40-minute appointment once you know how to do this. And then when you close the space, look how nice he looks. Mom's going to be super happy, and the patient's going to be all happy. And let's see who's talking in there. Can you see on that screen who's talking? Oh, anyway, no problem. So we have this chain to close the working space, and then we tie it together with a piece of wire so it can't reopen, called a ligature lacing. And you can see the blobby composite on here. That's not because I'm a hack. That's because I didn't want it to look too good, because I want them to get the final restorations when I finish the ortho. So here we come. The preparation for after the braces come off, a minimum of 1 month post ortho. And I have a clear overlay retainer. And you folks probably know this as an Essex retainer. Kind of looks like a hard bleaching tray. It fits the teeth perfectly because you made it over those provisional crowns. So on the day you prep the teeth, and notice that it looks like an over reduction, but they were peg laterals, right? So I had to over reduce like that to get them to work right. And then you lubricate the inside of this with separating medium, then put your temporary material in there like Pro Temp or whatever, and you get temporary crowns that fit perfectly inside of this clear retainer, which is a beautiful thing. And then when he comes back for the real crowns later, or veneers or whatever you like to do, then you'll make a new retainer, of course, for that. So let's go see how nicely that turned out. And 3 months post ortho, the crowns go in, everything looks good. The tissue just needs to heal up a little bit, but those look beautiful. Most hygienists probably wouldn't even notice that those are crowns. They would just clean right over the top of them and just go on their merry way. So again, a beautiful, beautiful finish for a problem with those peg laterals. And again, doctors, now I want you to start thinking about your restorative cases. And look at how nasty this one is, a 50-plus-year-old guy, class 2, division 2. Look at the wear on those lower incisors. So a pretty mutilated dentition. And, you know, I mean, I know what all of you are thinking right now. If it was just a restorative situation, you'd have to do a full mouth of crowns on one arch or the other to open the vertical dimension back up again, and then do the crowns on the upper. But you're focused on the wrong thing. You should be looking at what the malocclusion is before you start on that. And notice this class 2, division 2 pattern with small upper lateral incisors. And when you have a class 2, division 2 type malocclusion, many general dentists don't even notice that there's a problem, because they see, you know, pretty good interdigitation of the, and the teeth fit together in the back, and they just think, oh, gee, I'm going to put crowns on the 6 front teeth or the 4 front teeth to make them look better. And usually that turns into a disaster within 5 to 10 years. And if you've been around long enough, you know that's true. So let's go look at the rest of the case. And severe wear on the back of the upper front ones too, but not much crowding in the bottom. So that looks pretty nice. So we'll put some braces on this guy, and then we'll advance the upper incisors. And going to advance the upper incisors so we can get some room on the bottom, and we can provide, more importantly, to provide the right angulation for the upper incisors. And then we go into a heat wire, and I wish my want my link here this way, so give me a moment. And I'm going to have to get the share up on the screen here for a minute. So let me stop that one and start this one. And yep, so you're good. And I will do the narration here on this one. So this is a piece of this wire. We call it 18 by 25 heat activated NiTi. And it's nickel titanium alloyed with copper. And this is a proprietary combination of materials. But what happens between cold and hot, it changes phase. So watch as we go through here. And you've got this heat activated NiTi, and it comes out of the bag, and it's 72 degrees. It's room temperature, 20 C. And you can bend it. It doesn't feel like much of anything. It just bends like a coat hanger kind of would bend. And it doesn't seem like it has any memory, or not much memory. You can see that doesn't look like it would straighten teeth out very well at all. But it's never going to be used at room temperature, so that's not a big deal. All right, so what happens in orthodontics, we're going to activate this wire. And first, we're going to chill it to make it be dead soft. So you apply some kind of a cold source to it, so it takes the heat out of the wire. Now you can wad it up like a piece of spaghetti, and it just sits there. It does nothing. And this is to help you tie it into difficult teeth to tie in, or severely malplaced teeth. And watch what happens when the lip touches it again, and it turns back into 34 C, or mouth temperature at 98 degrees. And it goes instantly back to its same shape. And it'll do that over and over and over again, month after month after month. So until it makes the teeth get straight and it moves the roots. That's the most important thing. So let me turn this one off now, and I'm going to go back to my other share and get that here. So again, I'm so apologize that I can't use my normal thing, because these incisors need to have, the roots need to go to the lingual, the crowns need to go to the labial to a normal inclination. That's what the problem with this case. That is the main problem. So let me keep going down here. And you can see that it's starting to develop, that the premaxillary area is being resolved by the wire leveling. They were super over erupted. Now they're moving up and they're moving forward. And they keep moving up and forward until we can finally get some composite on the lower incisors. And then we're going to put brackets on top of the composite, because the brackets don't stick well to dentin, and we need to build them up anyway. So we just keep going, and notice from 100% deep bite down to 0% deep bite in simply 14 months. That's very, very incredible, in case you don't recognize that. So a severe malocclusion being corrected pretty easily. Okay. And month 26, some veneers were placed on the lower arch, and later the patient was going to do crowns all over the place, but for right now, that's all he can do. So that's what we're going to do for him. Okay. So the occlusion is far from perfect, that's for sure, but at least it's way better than it was before, and more conservative than a full mouth rehab. That means like 28 crowns, or orthodontic surgery, which is the normal way we treat class 2 division 2s. So very, very nice adjunct to your restorative work. And here's one more. Maybe this is somebody joining us. Steve Lynch. Hi. What do you need, Dr. Steve? Anything? You can turn your mic on. No. Hi. And so back here, another prosthetic case, age 37, and I'm calling this a pre-prosthetic alignment. So it doesn't look too bad right here, but this side looks pretty hacky with a crossbite in the cuspid. And wait till you see the bridge work underneath here. And the guy did the best he could, but it's still not very nice at all. And like I said, a great big giant bridge through here. So that's a 1, 2, 3, 4, 5 unit bridge here, and then a 3 unit bridge on that side, plus some missing teeth and a lot of restorative up here that needs to get redone. So today with some ortho, we can make this into a much nicer case. And look at this poor situation. The cuspid drifted forward, this bicuspid drifted back. You've got a Mickey Mouse cantilever ponic here, and a little ponic here that's too small for anything, a missing tooth here, and a giant missing tooth here. So let's go see what we can do. And in 13 short months, which is pretty fast, we have another chat. Let me see what this says. Oh, thanks, Steve. And so we have in 13 months, we have a pretty nice setup. Let's go look at what this would be like for the restorative now. And here we push the 4-5. That's remember the second bicuspid on the right side back. And the wire splint was placed in there to make sure the teeth are held in position. So now you've got a tooth, a space, a tooth, a space, and a tooth. You know, that's the ideal setup for a bridge work. And we might as well do bridges because, you know, these teeth are so compromised anyway. Today, you would probably want to do implants, but either way, you have to restore it. But look at how beautiful this setup is. Everything is where it should be. All the roots are straight up and down. You've got the ideal ponic spaces in each one of these things. And that's a short treatment time for 14 months. Much better than what you could do with any kind of restorative. Ortho made that possible. So that's really a nice service for the patient. Okay. And here it is after the prosthetics, and this is 30 months post ortho. And she got a really nice finish with some nice bridge work in there because it's a super old case. We didn't do bridge work back then. Okay. Plus, I don't like that pink color anymore. I just stopped wearing that a long time ago. That was a joke, doctors. And so think of the restorative options that you would have here if you just met this patient. You know, this tipped over thing, you and I have all done bridges on here, and we've done implants, leaving this big giant triangle underneath here. And you know what a food trap that is and what a pain in the butt that is. So, you know, we could improve this and we could make a much, much nicer case out of this. This isn't big enough for a ponic or anything. So knowing some ortho would have a profound influence on what you do every single day in dentistry. And I mean, every day. Right? And here's an impacted cuspid case. I just want to get this in. I know I'm getting short on time, so I'm going to speed it up a little bit. And you've got a missing cuspid here, one missing cuspid here, and one more down here for 3 of them. So missing 3, let's see where they are. And doctors, they are impacted on the upper, and that means it's overlapped of the lateral root. So that's not going to come in by itself. This girl is 14. That's 2 years past normal eruption time. The lower is simply blocked out. All you have to do is open space here and that'll come in. Okay. And let me go here. And we get to the expose and attach and the suture removal. And one of them, the attachment failed. The other one stayed on there, but it'll still work. It's going to come in okay. And oh, doctors, we're lucky. We have joining us now a legend in his own mind, Dr. Shockley Weir, one of our famous POS instructors. He's a tenured instructor, and we'll have a chat with him in just a minute, but let me finish this.
Thank you, my friend.
And let me get out of here. How was your workday, sir? And here we had the suture removal. Let's go back to work on this young lady. And suture removal. And then here at the finish at 22 months, everything is in. We brought all the cuspid occlusion. Looks really nice. Everything is nice. A little bit shy of occlusion right here, but that'll settle in later. And then here we have, oh, it looks like we're not tracking very well. No one pointed that out to me. Let's see what's going on here. Derek, are you still with me, sir?
Yeah, we see. I mean, we see you moving the slides right now.
Yeah. And I'm looking at a Panorex picture, and so are you, yeah?
I'm looking at 2 upper impacts and 1 lower blocked out cuspid.
Yeah, perfect. So we're in the right spot. Okay, just my other computer didn't look like it was tracking very well. So let me go back to work here. And we were at the finish. Everything was looking good, except we had a little bit of an open bite back here, but that'll settle once the patient's out of retainers at 6-month time and they go to sleep time only for retainers. Nice straight teeth. Everything looks good. And how do we do? Looks really good. The roots are all nice and parallel. So remember, doctors, clinical success is the ultimate test. That's the best thing ever. Does it look good? Does it work well? And is it going to last? And certainly this patient will qualify as that. And you get another one that's kind of messed up, age 15 at start with some pretty bad impactions. And again, if you didn't know general dentistry, I mean, if you didn't know ortho, this would be a very tough situation for a general dentist. So we're going to bring them in. And this is a scary thing, doctors. When you bring in these cuspids like that, it can cause a lot of unwanted movements on the adjacent teeth. And you don't know, is this a good thing or is this a bad thing? And usually it's okay. You want those roots to get out of the way of those cuspids. And common sense would help you a lot here to understand that the cuspids are probably on the labial. That's why this clinical crown is so far to labial, because the root is so far to the lingual. So that's probably the position of the cuspid. Let's go see what we can find out here. And we made the space and then we attach them and bring these little chains are going to bring the teeth in with this nickel titanium flexible wire. I couldn't show you that because the link didn't work, but later we'll get them all the way in, and then all that deleterious movement on the incisor goes away. It looks like a beautiful finish. Everything is great. So all good. And did the cuspid cause the pulpal damage to the 1-2? And the answer is probably not. This probably was due to something else, but we always have to have an signed consent form whenever we do ortho, just like any aspect of general dentistry. And for those of my doctors here with us tonight that are from California, you know, you as the doctor have to present the informed consent. You can't delegate that to a dental assistant, sorry to say. And let's see how we did here at the end. Ooh, this is another weird one where the first bicuspids were taken out. And look at this one, how severely impacted this guy is down here. That's really, really a bad one. And, you know, it's just a matter of time. And once you make the space and bring it in, and we call this a piggyback wire, and I don't have time to explain to you why that is, but here we just keep going until we get that thing into position, and you finally get it in position, and then you can start closing the case up. So this might be a 4.5 or a 5 year case, but at least, you know, we get the thing solved and we get that resolved. And then I got one more here, and then we'll look at this guy. This is a true transposition. So age 20, and you'll see what the chief complaint is right here. And this is another one. Imagine what in the world would you do with this from a restorative dentist standpoint? You know, and I know what you would do. You would take out the cuspid and then put a cuspid crown on the lateral or something else, and then maybe, I don't know, an implant in here or some other option. But boy, you know, if that were my son, I would much rather have a full complement of natural teeth in there. So we're going to bring that in, and it's going to take a long time. And look at what a true transposition this is. The root and the crown are in the wrong place for both of these teeth. And then that's a baby cuspid right there, obviously. So here we go. 4 years later, well, 3.5 years later, and we finally got it in. And that's what that looks like. So again, all these are done by general dentists that are, you know, doing ortho. So if these guys can do it, I know you can do it as well. So they asked me to say a word. Dr. Rue says, what's the best age ortho? And I would say the best age to start looking at that is at age 8. You have a full complement of incisors in there, 4 uppers and 4 lowers. Then you can make a statement about the amount of crowding that you have, and then you can look at the class 2 and 3 and so forth and figure out what to do. So age 8 would be the best time to look for that. And again, the POS admin staff asked me to talk about this. And how are you going to find your ortho patients? And you don't find them. They find you when they arrive at your office. So this is where you get patients from within your own office. And I want to say here too, that every single exam that you do from now on, assuming you join us, of course, you're going to do the health history, vital signs, radiographs, photographs, oral path, blah, 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 blah. Same thing you do right now, plus an oral orthodontic exam and screening. And doctors, this is how you get your new patients. And I look at my assistant and I say, hey, are you ready? And she goes, yep. And I'll say, I have a class 2 division 1 with a 4 on the right and a 3 on the left and 6 millimeter crowding on the bottom and 6 millimeter crowding on the upper. And the patient says, hey, doc, what's all that about? Because they've never heard anybody talk about that before. And I say, gee, that's how far off your bite is. And this is how we start the conversation with the patient. So they'll say, hey, what was all that information? Because, you know, patients know about their perial pockets and they know all that stuff because they've heard it so many times, but they probably have never heard about ortho before, right? So you tell them about their bite relationship and what that looks like. And think of all those kids that you have or should have referred to an orthodontist. And once you know that what to look for and how to find it, the number of these patients will multiply exponentially. So once you join us, it's a very, very powerful adjunct to your practice. Okay. And talk about armamentarium for torquing roots, especially in the case of cuspid retrieval and unwanted anterior moves. Doc, that's a really good question. If you can hang with us at the end, I will explain that for you. But for right now, let me address this to my beginning docs. Okay. And Dr. Shockley Weir, who just joined us a few minutes ago, the world famous Shockley Weir, I should say, he made up this little list of things to look for in a mixed dentition case, so that when you have this list, doctor, this is the thing where you would look on here and you would say, you know, Dr. Ruth, you could be asking yourself, are any of these things present in the patient that you need to fix, like, you know, transverse dimension to have crossbite, missing teeth habits, open bite, deep bite, all that kind of stuff. So you would get that list, and we give you that list somewhere in there. And again, for this initial exam, we use this thing called a gray form. And in our new software, it has exactly the same thing on here, but we just fill out this front page on paper and then transfer that to the chart later. And we use that as a screening device. And, oh, here's a great question from Dr. Zhang. Do you recommend that we refer class 3 patients out? And the answer is no. Class 3s are no more difficult to treat than class 2s, in my opinion. I don't know why, but the orthodontic community is tremendously scared of them. And every time a class 3 walks in their office, they just say orthodontic surgery. That's their answer for every class 3 case. It's so funny. But all you have to do is just manage the growth, and class 3 is no more a big deal than class 2 is, in my opinion. So I'm not worried about that at all. But for some reason, most people are worried about class 3. Okay, so where am I here? So that one-page checklist. So PDS can supply you with one of those things, but you don't know how to fill it out yet, but you will once you join us. So most orthodontists in America don't see patients less than 12 years old. So this could be a huge market for you. And just think about the huge benefit to your patient. You know, many of them don't know that they have an orthodontic problem, and they wait till it's like they're, you know, age 14 or whatever, and then it's either extract something or not. But if you start on these kids when they're young, then maybe you could eliminate a lot of extraction and a lot easier therapy when they're young. Okay. And you have to have full, complete records, and we'll go over that in the class. I don't want to bore you with that stuff right now, but that's mandatory for doing ortho. So remember, if you're only putting one bracket on a tooth, then you don't need full records. But if you put 2 brackets, then you're actually doing ortho, then you need records. Because too many orthodontists, too many GPs, excuse me, all they do is take a mud pie and a Panorex. That means a couple of alginates and a Panorex, and they do ortho with that. And that's why GP ortho has such a bad name. Okay. And again, I don't want to get through all that stuff, but I want to thank you for your participation in that. At 6:30, my time is up. And I hope you'll join us in the POS family and incorporate ortho into your practice. It's not hard. It just has a pretty steep learning curve, and you just have to put in the time to make that happen. And Dr. Schock is with us now, and he's going to say a couple of words. Are you still with us, Schock?
I am. Thank you for inviting me to the class, and welcome to all of you. I appreciate it. Dr. Taylor, I've known Dr. Taylor for a long, long time. Dr. Taylor was one of my original mentors way back when. So the guys knows what he's talking about.
Let me have that mic back again. So I was the instructor for this class in New York, and Dr. Schock came in there, and the first day he presented 10 sets of records for cases, and this was the first seminar that you could do that in. And the other students
I'm going to interrupt you. It was 12.
Oh, 12, excuse me. So the other students were mad at him because he took up all the diagnostic time, but now he's going to tell you what orthodontics did for his practice from that day forward. So tell him about the operatory and all that stuff.
Okay. So, well, I mean, I started off with, I'll tell you my story. I started off, I used to take Medicaid, okay? And Medicaid was not very profitable in my practice. It was a lot of paperwork, a lot of time for very little reimbursement. This is a true story. And I didn't even know he was going to ask me this question. And you know what? I replaced the Medicaid portion of my practice with orthodontics. I'm telling you that you already have the patients within your practice. And here's the deal. All the patients and the parents know that the children need ortho. They are just waiting for the dentist to tell the parents when it's the appropriate time to put the braces on. Now, the disservice from the most dental schools in the United States is they don't tell you even what to look for. I've taught this all over the world, and the issue is they don't tell you how to evaluate a child. So most dentists, since they're uneducated, they wait until the malocclusion fully expresses itself, which is a huge disservice to the child, okay? So you have a huge pool of patients. In addition, just as a side note, orthodontics is much more profitable than dentistry because the overhead in dentistry is insane, and the overhead in ortho is exceedingly small. Okay, so I went from that to the point where, so this is my story. I went to the point where I stopped taking it. I started 150 cases in 2 years. Okay, and that's just word of mouth in a small town. Okay, no advertising. That's what it was. And now that was 20 years ago. Now I'm to the point I practice in a specialty practice with an orthodontist, and all I do is ortho. And I hired a dentist who does all the dentistry at my office, and I do ortho there 1 day a week. So, and all that education comes from this company. So, and I work with a specialist all week. So I know I did 48 hours of clinical ortho this week. Okay, that's a lot. So I know what's going on out there, and I can tell you that if you get educated with POS, all the sources are available to you to treat any case that you want in your practice. And the other thing that will set this company apart from the entire world is you have continued customer support from the very beginning until the end. I have students that I started diagnosing cases for 20 years ago. And you know what? If they have a question about a case every now and then, they email me. So what I'm saying is, once you get in the program, you become part of the family. So you're always going to have support. The worst thing that's ever going to happen on a patient, it's something unexpected happens. You go in and you look at the case and it looks different than what you would expect. A lot of courses, you're on an island and then you get frustrated. You don't know what to do, so you quit. This system is set up so all you do is take photographs of that progress patient, send it to any of us instructors. We'll evaluate the patient, tell you what to do so that you can go in and look competent in front of your patient and provide quality orthodontic care. And the other thing that I'll guarantee you, and then I'll stop giving you the sales pitch, is I'll personally promise you, I'll give you my email and you can call me out on it. The quality of care that you will provide will be above the level of the specialty. Okay.
I would agree with that.
It's not some I practice in the specialty. It's not some Mickey Mouse system that you're going to learn. Okay. The quality of ortho that you're going to provide in your office is going to exceed 90% of the specialists in your area. And you can call me out on that personally. I will personally guarantee you that. So there's a sales pitch for you. So I'll shut up now, guys. So.
Yeah, and then we offer a whole alignment series, an aligner series too, because we all know how popular that is today. And that's the patients all want that. So we have an extended aligner program of 12 days. And then Shock engineered a 3-day program for aligner basics or aligner advanced. And that's a nice adjunct if you're doing aligner therapy.
Yeah, if you know I'm going to interrupt again. If you already know orthodontics, you don't need to take an extended course that's going to teach you the basics of orthodontics. Let's just skip all that and let's just cut to the chase. And then let me teach you how to use the piece of plastic. Okay. But if you don't have orthodontic knowledge, then if you take that 3-day course, you're not going to understand it. It's going to be above your level. You need to have a more extended course that gives you the basic education that you need so that you can follow along in something that is more succinct.
Thank you, Dr. Shock. Well, you can go back to relaxing because it's 9:37 p.m. for you. So thanks for coming by, my friend. I will talk to you probably in about a day or two. All right, now.
Good night, my friend. Have a good night. Thank you, everybody, for letting me pop in.
Thank you. Dr. Kazan, you want to know about what armamentarium would you use for torquing the roots, especially in a case of cuspid retrieval, unwanted anterior movements. And you're probably familiar with regular orthodontic brackets, and they have 2 torques for upper incisors, and they usually have just high torque, that's we call it LI, and about 22 degrees, and then Roth is plus 12 degrees. They have 2, we have 4. And for the lower, they have 1 and we have 5. So we have very, very torque specific brackets that we can use to help fix all those things that the cuspid messes up when it comes in. So if you're familiar with a thing called the piggyback technique, this is all for you, Dr. Mehran. And a piggyback technique, we always use round wire in there. We never use rectangular wire because we want the roots to get out of the way to have complete freedom to allow the cuspid to come in. But once the cuspid comes in, then that heat activated NiTi wire I showed you, plus this torque specific brackets we have, will put the roots in the right place. It's not fast, but it is very effective at doing that. Okay, so that's the short version for that. And here's another very important question. Dr. I can't read the rest of your name, Gisela. And it says, she sees, it seems like you need a lot of equipment to do ortho. And is it better to start with aligners or traditional ortho for a fast return on investment purchase of the pano? And I would say you should start with conventional ortho. And when you think about return on investment, you know, all of you who've done implant stuff, you know, the kit's at least $25,000 or $30,000 for that. And for that much money, you could buy our education kit and you can get a Panorex machine, almost that kind of stuff. So I think you're a lot better off doing ortho using that kind of money. But the aligner thing, you still should have full records for every aligner case. I know that aligner companies don't tell you that, but you really should. And I think you need to know traditional ortho so you can know how teeth move before you can do aligner therapy well. So I hope that answered that question. And let me go see if there's anything else in here, but not a name. So you want to put the name on there. And oh, you have learned ortho from POS and been doing it 15 years. And I agree with what Dr. Weir says 100%. Well, thank you for that endorsement. And so from Steve Lynch. And Steve, how long have you been doing ortho now? Almost as long as me, right? 40, 35 years?
I retired, but I did it for 35 years. I took POS right out of dental school.
Perfect.
And so glad I did.
Yeah, and think about that profound impact it had on your practice, you know, after all that time and all the cases that you treated and how thankful your patients were for that.
Well, you know, honestly, POS, Progressive Ortho, teaches us the exact way the specialists do ortho. It's not some funky way. And so I had a great relationship with my orthodontic specialist because I could talk their language and I did everything the same. That's how POS teaches. It's not a weird way to teach. And I love that you weren't grinding teeth down. It was a wonderful way. When you finished, you hadn't done any drilling on the teeth. And that's a really great way. And for me, orthodontics didn't take any selling at all. Parents know that if there's crooked teeth, they need braces, and they're waiting for you, like Dr. Weir said, they're waiting for you to tell them when to do their orthodontics. And they don't want to go anywhere else. They want to stay in your office. They don't want to go to a new office to a specialist. And it changed my career. It was wonderful.
100% right. It's so much more fun to do ortho than it is to do dentistry, you know, and I still do regular dentistry. And, you know, it's just a drag compared to doing ortho. It's a challenge. It's a lot more complex than doing an occlusal composite. But how many more of those do you need to do, doctors, before you've done enough of them? And it's just dumb. You know, patients come in there and I hate the injection. I hate being here and I hate all that stuff. They never say any of that stuff for ortho. They go, hey, look at how good this looks. Aren't you excited? I mean, look how fast it's correcting and so on. So ortho is really, really a huge boon to your practice, docs. So POS staff is saying, send them my email or direct number. It's important for you to receive your CE credit. So if you're into it for the CE credit, the whopping one of them, then go ahead and send that in. You can contact the admin staff. And here's our phone number. It's 949-619-7599. And the email is just going to be amalia@posortho.net, not .com, but .net. Okay. Perfect.
Thank you, Dr. Taylor.
All right, thank you. Any other questions? I can hang for a minute if you've got anything else, docs. All good? All right. And Steve, before I let you go, how many grandkids now?
Two.
Two.
Two little boys.
I have a question.
Yes, Doc.
Yeah, what was the you mentioned at the beginning the website where you can do the ortho models,
Oh, I would look up Ortho Select.
No,
Ortho Select.
not for the diagnosis, but you said that there was some kind of, I
Yes.
think,
In other words, it's a diagnostic service for the models. And look up orthoselect.com.
no, I have Ortho Select.
Okay,
But
then what was the question? Maybe I don't understand.
It was different. I think it was dental.
Oh, well, that one, dentalemodels.com. And they're almost as twice as expensive as Ortho Select. What do you find wrong with Ortho Select, doctor?
I'm sorry. No. I just wanted to know more. That's all. But I work with Ortho Select. So.
Oh, good. Dental E-Models was the first one to ever hit the market. That's why we started using it, because it was the first one on the market. And then after all the copycat ones came along, and now like Ortho Select, I believe, is just half the price of Dental E-Models.
Oh, okay.
All right.
Thank you.
And thank you all for those kind words. I certainly appreciate it. Anything else from anybody? And I'm so sorry that the Zoom thing didn't work. Maybe my POS admin staff can hang with me for a minute. Maybe we can figure out why it didn't work. But again, so I'll end the meeting for us, I guess, or you can still ask a question. I'm here for a few more minutes. All good. All right, doctors, thank you again for everything. I certainly appreciate it, and have a good